If you distill the fundamental idea of healthcare down to its purest, most unadulterated form, the essence of it just seems so simple. When someone is sick, they should get the care that they need. And this should be true for all of us humans living right now, forever on the cutting edge of the future, riding around on this blue and green orb through the universe and living our shared history as a species. But there's a heartbreaking reality to healthcare, and cancer in particular. The messy and upsetting truth is that the number of people who can get the best care, if we can even agree on what that means, which we can't, is fractional. Untold numbers of people can't even get decent care, and millions of people get absolutely no care at all. So why is that? There are glaring, enormous problems plaguing medicine and medical systems around the world. How do we unwind them? How do we even understand them? And for all the individuals in the world with cancer who are struggling, how can we bring them within reach? Can we create actionable solutions that alter the course of their disease and of their lives? It's a lofty goal, but it's the one we're going to tackle right here. I'm Evan Young, and this is Within Reach from Avalere Health. People in Janet Kerrigan's orbit would describe her as a steamroller. Not in a bad way, mind you. Janet's full of energy and a sharp wit, and she's a deeply social person. Whether it was during 13-hour days as a critical care nurse or outside of work with her friends and family, always planning trips or get-togethers, Janet was the one in the middle of the action. She was even her daughter's wedding planner. But a piercing pain in her right shoulder, just weeks after her daughter's wedding, dropped her. Literally, to her knees in pain. It was during a shift on the job and the staff around her thought it was a heart attack. But testing revealed something different: multiple myeloma. A few weeks before, she was in the middle of the dance floor at her daughter's wedding reception, dancing up a storm. And now, in 2011, at age 55, this is what the doctor told her. She had a terminal disease and 1 to 2 years left to live. I talked to Janet about all of this in May 2026. Now, I'm no expert in math, but by my calculation, it's been about 15 years for Janet since that initial dire diagnosis. I won't share with you too much of the other incredibly challenging parts of Janet's story, which includes her husband's own battle with cancer and the financial fallout that came down on Janet and her family like an avalanche, stripping her of her savings, her retirement, and nearly her house in those first few years of her treatment. And I won't share all the lighter parts, except to say that when Janet lost her hair during chemotherapy, she gave her wig the nickname Harriet, which is really the best nickname for a wig that I've ever heard. But I will share that Janet was able to crack jokes like this with me about her experiences because the field of multiple myeloma, like many other cancers, has undergone an extraordinary series of treatment developments since 2011. So while lenalidomide was the drug that took her hair, back in 2011 it was only a few years old. But then, 2012 saw a new drug approval, which Janet started taking. In 2013, another approval. In 2015, 2 more new approvals. At every turn, Janet's treatment options expanded, and she kept on rolling. In 2021 came the CAR-Ts, and in Janet's fight against MM, this was the break she needed. Safe to say that if Janet is a steamroller of a woman, the pace of innovation in oncology is right there with her. But for healthcare providers, this seemingly never-ending cascade of treatment advances does come at a cost. It's impossible to keep up with every advancement. The deluge of information pours in constantly. Prior authorizations needed, biomarkers to be tested for, insurance to navigate, and care to coordinate. So while the pace of innovation is breakneck, the time to spend with patients goes down, decision fatigue is real, and burnout sets in. With my 2 guests today, Amy Pierre, Senior Clinical Director at Flatiron Health and Board Member at the Advanced Practitioner Society for Hematology and Oncology, and Jahda Hill, Senior Vice President, Medical and Scientific Affairs at Avalere Health, we discuss these real issues riding along with innovation, what we can do about them, and more. That's all coming up next on Within Reach. Jahda, Amy, thank you so much for joining. I'm really looking forward to this conversation. I hope you are too. I think it's going to be a great one.
I think so too. I'm excited to be here. Thanks for having me.
I think we can start by saying, thanks to Einstein, right? We're all aware that time's not a constant, but we are earthbound humans. And for us, for all intents and purposes, there are still only 24 hours in a day. So when we think about the struggle to keep up with the pace of innovation, and we talk about and think about oncology as an infrastructure and a system of care that is meant to help and treat people with cancer, I do think an interesting way to start on the topic of how doctors can keep up with that pace of innovation is really to first focus on time. So, Amy, if we could start with you, do doctors have enough time? And is that really the right way to start thinking about it? Is time the critical missing element here?
So this is a really interesting concept. And I think that question really resonates with me because I've sort of lived this from two very different vantage points. So as an oncology nurse practitioner, I've spent years at the bedside trying to translate rapidly evolving science into real care decisions for real patients. And now in my role at Flatiron Health as a clinical director, I spend my days studying what actually happens when that science meets the real world. And I can tell you the gap between the two can be significant. And that has really profound consequences for patients, particularly those who are already marginalized. So I think we really need to think about sort of what keeping up means. That can be something very different depending on who you are, where you practice. And that's part of the conversation that doesn't really get talked about enough. So for an oncologist at a major academic center with a dedicated research team who has access to grand rounds and journal clubs and colleagues on the hall who specialize in the exact tumor type you're treating, keeping up is hard, but it's structurally supported. There are systems around you designed to help you do it. But for, an NP or a physician in a community oncology practice, where the majority of cancer patients in the United States are getting their care, keeping up looks very different. You may be the only advanced practice provider covering multiple tumor types. So you're seeing a full patient load, you're managing prior authorizations, patient navigation, care coordination, often all at once. And you're trying to simultaneously absorb the fact that the treatment landscape for, say, multiple myeloma has transformed almost beyond recognition in the past 5 years alone. But I think we need to look at how to really frame the question. We've been framing keeping up as almost an individual healthcare provider problem, as if the solution is just more continuing education credits, better journal subscriptions, smarter time management. But the research that we've done here at Flatiron can tell a really different story. And I've studied what happens when innovation reaches the real world, and the data really can be sobering. So we looked at access specifically to bispecific antibodies, which is one of the most new exciting treatment classes in heme malignancies. We looked at across about 2,000 patients with different heme malignancies, including diffuse large B-cell lymphoma, follicular lymphoma, multiple myeloma. And what we found was that patients living in the highest socioeconomic status neighborhoods were more likely to initiate these novel therapies compared to patients in lower socioeconomic neighborhoods. And patients who lived in predominantly Latinx or Hispanic neighborhoods were 52% less likely to receive these treatments at all. So this isn't really simply a story about healthcare providers not knowing enough. It's a story about structural inequity and how innovation flows through the healthcare system. And it isn't just, does the oncologist know about bispecific antibodies? It's, does the patient have access to a practice that offers them? Does their insurance cover them? Do they live close enough to receive them? Do they have the transportation, the time off the work, the language to support the system? So this is where keeping up conversations gets really important, because it's when the healthcare providers at community practice don't have the infrastructure, they don't have the time or the support to integrate new therapies into their practice. It's not just an inconvenience for them, it's a very real inequity for their patients.
I heard a whole lot of things in there that I think are fascinating and interesting and even a little bit terrifying. The first thing I think of when I think about what's terrifying is asking a community oncologist to be an expert on multiple cancer types at the same time. That's mind-boggling, and I can't imagine what that must be like for that physician. But Jahda, I think for you to think about any of the things that Amy just said, I mean, what are your reactions there?
Yeah, I have many reactions because you listed a whole host of factors. Just to go back to the first one that you just mentioned, though, is the lack of specialization in the community. And it's reality and unavoidable. When we come back to that original question about just knowledge of what's out there, does the average community oncologist get to ASCO every year to learn about things? And obviously when they're, at a big conference, they're learning about what's in development, but do they even have time to learn about the new modalities that are approved? One thing that I've heard in talking with community oncologists is that they value interacting with their academic colleagues to learn about some of these new innovations that are available to them. To what extent are they able to do that frequently? And then as a nurse practitioner, Amy, how much of that gets out to those advanced practice practitioners as well within those groups?
That's very interesting what you say, because what I find is this sort of peer-to-peer networking and sort of peer-to-peer style tumor boarding is what really is impactful and where clinicians find the most education useful for them, the sort of the real-time case-based studies. So like you said, not everyone can get to a conference, right? So I think a community oncologist wants a real-time tumor board, someone to call when they're facing a complex case with a rare mutation. Learning from real cases in real time with real stakes. That's a lot more effective than the abstract didactic education. So these peer-to-peer learning networks, these tumor boards, these case-based continuing education formats, that's why they're so valuable. And I think that's why we need to invest in making them more accessible to clinicians in underserved settings. And a community oncologist covering multiple tumor types needs a very different education than, for example, a specialist advanced practitioner focused exclusively on multiple myeloma. So a clinician in a rural practice with limited access to novel therapies needs different information than one in an academic center. So effective modern education needs to meet clinicians where they are in their practice type, their patient population, their specific knowledge gaps. And then the best education in the world is equity conscious, right? It doesn't help if it only reaches clinicians who already have the most resources. So we need to design educational systems that actively reach community and rural providers through telehealth tumor boards and digital platforms and mobile accessible resources and peer networks that can bridge the academic and community settings. Because ultimately, the goal of the healthcare provider education isn't just to make individual clinicians smarter. It's to ensure that every patient, regardless of where they live or who their provider is, has access to the best possible care.
Thanks for bringing it back to that, because that was another one of those initial factors I think that's worth spending a little time on. So you mentioned the example of bispecifics and many patients not living in an area where there's even a practice that has access to those. So how much of it is resources, sort of logistical barrier to just not being able to have them in the community? And is there an ability or an awareness of, I don't have this, but I think that this is probably the best approach for this patient, so I need to refer them out to a different place where they can get access to this? Do you have an idea of how much that's happening, or how much physicians in the community may be having to hold on to a patient because they either don't want to refer or don't think that their patient would go somewhere else for care if they were to refer them?
I think you do have both scenarios. I think you have some community oncologists or providers that are very willing to understand sort of the limitations of their site and the structural barriers that they have, and have partnerships with academic centers that they can refer their patients out when they know there's a clinical trial that might be good for them, or they know they can adequately provide them the inpatient step-up dosing that a bispecific may require, or refer them out to a stem cell transplant center because they don't have the infrastructure to do that. So those oncologists are very much in partnership with colleagues and academic centers and have that network in place to refer their patients. And then, sad to say, reality, you do have some community oncologists who I think are afraid to refer their patients because of the loss in financials, right? So if you refer that patient out, they may not come back, and that could be a lost patient in your caseload. But obviously that is not considering the patient in the forefront in the care. You're sort of considering your practice in the forefront. I think we are living in a world where oncologists are understanding that their patients need to get the care that they need and are willing to refer them out for what they need.
Yeah. And I do wonder how much of this can be attributed to them, back to the original question, just not being aware of the quality of the data or the evidence for the newer bispecifics that have come out. Do you think that factors into it as well?
Yeah. So let me start with a number that I think captures this problem better than any. So in 2024, the FDA had issued more than 60 oncology approvals. That's 60 approvals in 1 year. And that's just the FDA approvals. That doesn't count the hundreds of conference abstracts, journal publications, updated guidelines, and new biomarker data that lands in an oncologist's inbox every single week. So the medical literature has increased past the point where a healthcare provider could not even keep up, even if they did nothing but read journals all day long, every single day. So I think what we can do is try and build systems and networks for filtering this type of information. So when a community oncologist, let's say in rural Georgia, encounters a patient with a rare EGFR mutation variant, they're not going to find the answer in the journal in time. They're going to call a colleague, they're going to reach out to a specialist or tap into a tumor board. So like we talked about, the peer-to-peer learning is irreplaceable. It's one of the most underinvested resources in oncology. And when we talk about point of care clinical decision support, this is where tools like we have Flatiron Assist at Flatiron. It really is genuinely transformative, not because it replaces clinical judgment, but because it actually surfaces the right information at the right moment inside the clinical workflow without requiring the clinician to leave what they're doing. So when a clinician is ordering a regimen for a patient with, let's say, metastatic non-small cell lung cancer and a rare biomarker, they don't need to remember every clinical guideline update from the last 6 months. They need the relevant NCCN clinical practice guidelines, the preferred regimen for the practice, and any relevant clinical trials surface right there in the ordering workflow. But, my patients and the patients of community oncologists across the country often look nothing like those trial patients. They're older. They have more comorbidities. They're more racially and ethnically diverse. They're more likely to be on multiple medications. So things like real-world evidence can tell you what actually happens when a therapy is used in patients who look like your patient. And that could be very different and often more actionable kind of signal.
So I think there's something interesting here that I would love to also just talk about. And that's, we're talking about keeping up with the pace of innovation, but that is about the medical innovation, I think, that's happening, treatments that are available, and the ways that we can better connect doctors to that information. But I think when we think about that better connection for doctors to get to the information that they need, it's almost as if additional innovation is the answer. So there's a really strange dichotomy between solving innovation with yet more innovation. And so, I mean, is that a principle that you see? Is that true in practice? And if so, how do we get doctors to be aware of like, hey, you've got a world of info out there. It's impossible to cover all of it, right? We know that. But to get to what's really relevant to you, you got to learn this tool. You got to self-educate on this thing. You got to tap into this channel, whatever the case may be.
So I think you're asking, can tools really help, or will they add complexity?
Mm-hmm. Yeah. And I think under that too, there's like an AI topic that we need to get to for sure, because it's looming so large in our business too.
Yes. So I think on the positive side, the data is really compelling. So things like AI scribe technology that's integrated in electronic health records has shown really high adoption rates among clinicians. And some providers report reduced documentation time, improved clinic flow, and even, decreased cognitive burden. So this mental offloading is what they sort of call it. And that the AI really capture the visit so thoroughly that they can think more clearly after the appointment rather than, rushing to document before they forget. And then we even have something called Deep Scribe here at Flatiron, which brings basically an ambient AI scribe to our electronic record system. So it listens to the clinician-patient conversation during a visit, automatically generates a structured context-aware clinical note directly into the electronic medical record system. So it really reduces the documentation burden on clinicians and offers patients more meaningful time with their provider, which is something that, as a healthcare practitioner, is one of the most difficult parts of your job, sort of that administrative burden and documentations. But not all AI tools reduce the cognitive workload, right? Some can increase it. And the research on that can be really sobering. So when a clinical decision support tool generates too many alerts, clinicians begin to override them reflexively, and not because the alerts are wrong, but because there are just too many of them to process. It's basically click fatigue. And a study actually found that clinicians were manually disabling the prompts entirely, which of course creates serious safety risks. So the problem really isn't technology, it's the design philosophy, right? So an AI tool that adds a new layer of clicks or a new screen to navigate, a new decision to be made for every patient interaction is not actually reducing cognitive load, it's adding to it. And I've seen this play out in real clinical settings. So what is the real difference between AI that helps and AI that harms? So I think, it needs to be integrated without interruption. The best tools work in the background of existing workflows and not as a separate system. And then I think AI tools that are trained on data, we need to be equity aware of the design. So AI tools that are trained on data from academic centers will not perform equally well for patients in the community setting or rural setting or underrepresented demographic groups. And then human oversight is a non-negotiable, right? So AI should be augmenting intelligence. It's not replacing our intelligence. The clinician's judgment, their relationship with the patient, their ability to integrate clinical data with the patient's values and life circumstances, that's irreplaceable. So the goal of AI is to give clinicians more time and better information to exercise judgment, but not replace it.
So one of the things you brought up that I do want to go back to isn't just around the technology, but it's around just pure information overload, where that information is coming from. And I do think it's the amount of friction between the doctor that needs the information and not even knowing where to get it or how best to get it, or even what that information might be, right? So if there's a new drug approval, for example, and that applies to one of their patients, I know you mentioned a bunch of different tools for doctors, but what do you see in terms of how we can just better get doctors to learning that that is even out there?
Yeah, firstly, I think we need to redesign how clinical knowledge reaches healthcare providers in these settings that have the structural barriers, such as community and rural settings. So it can't just be more journals, more continuing education credits, more conferences. Like I said, it needs to be embedded in the clinical workflow. So these decision support tools, real world evidence dashboards, the peer networks that connect community healthcare providers to specialists. I think that's really important because when a community oncologist can see data from patients who look like their patients treated in a setting like theirs, that's actionable in a way that a landmark randomized controlled trial often isn't. I think, secondly, we need to address the structural barriers that prevent patients from accessing the care their healthcare providers know about. So knowing about a therapy and being able to offer it are two different things. Transportation assistance, financial navigation, language support, telehealth infrastructure in areas with reliable broadband, these are not just nice to haves, they're necessary for equity. And some of the things that I'm working on at the Advanced Practitioner Society for Hematology Oncology, our Patient Advocacy Council, we're building a patient compass that consolidates resources from different patient advocacy organizations across transportation, financial assistance, home care support, and more. It's a direct response to this gap. We're trying to make it easier for healthcare providers and patients alike to find the support that they need to actually access the care that they need. And then I think we need to design innovation with equity in mind from the beginning, not just as an afterthought. At Flatiron, we actually did a study during the pandemic. We published an article in JAMA Network Open, where we analyzed over 50,000 patients across 5 different cancer types and found that Black patients were 43% less likely and Latinx patients were 46% less likely to participate in clinical trials compared to white patients. And these inequities were consistent across every single cancer type we studied. And critically, these inequities actually widened during the COVID-19 pandemic, a period where we were told that telehealth and virtual visits would democratize access. But we see that that actually wasn't the case. So that's sort of a cautionary tale, right? We cannot assume that new tools will automatically reach everyone equally. We have to ask at each step, who benefits from this innovation? Who gets left out? And what do we need to do differently to ensure that patients who are already most vulnerable are not the last to benefit? So obviously this is not easy. It's hard. It's slow. It requires all of us, researchers, clinicians, health systems, policymakers, and patients to really stay at the table together to make this happen.
So as you're talking about it, what I'm imagining is a physician has a patient who's just been diagnosed with some cancer. They've got some biomarker data. Community oncologist works across multiple tumor types, doesn't know exactly what treatment to prescribe, opens up their dashboard, maybe can pull up some guidelines, and they see 3 new treatments approved in the last year for this specific cancer type that this patient has. I guess what is helping the doctor make that decision in that moment when you start to talk about guidelines and you see multiple therapies sort of sitting there as a priority treatment or, a first line treatment option? So in the absence of having real world experience, with that treatment and a physician has, some AI tool that is telling them here are the latest things that are approved, how would they make that decision? And I guess in terms of the AI tools that are available to them, will it be easy for them to make that decision based on what's being fed to them with that seamlessly integrated tool?
So this is a great question. And I think we have to sort of contextualize how they're absorbing that information as well. So when they have the clinical decision support tool, sort of leveraging the clinical practice guidelines, showing them what is category 1 or preferred regimen, how do they then decide between the few that might be presented to them? I think they have to look at the individual patient, right? And that's also where shared decision making comes into play. Because one particular regimen can carry a lot more toxicity and frequent visits, but maybe more efficacious. And the other one might have less clinical visits, might be an oral option, and that might more align with the patient's goals of care. So I think that's when you sort of discuss all the options with the patient and lay it out for them and say, hey, the latest and greatest shows me that we actually have these 3 options to choose from. And I can explain to you why I would recommend each one after maybe consulting with my expert in this academic center or talking to this expert in this peer network, or after researching and listening to this case-based study. I feel like these 3 are most aligned with what you should do. And here are the pros and cons for each one. And then you tell me what you think your concerns are, your questions are about each one of these therapies and how it aligns with your goals of what you want to do. It also depends on where the patient is in their disease trajectory, right? Someone who's newly diagnosed is probably going to be super aggressive, and they're going to want to do the most efficacious therapy that might carry the highest toxicity. But someone who's in their 4th, 5th, 6th line of therapy, they're now focused on, I just want to be able to go to my granddaughter's wedding. And so what regimen will allow me to take the time and feel well enough to do that? Which one has the flexibility that allows me to continue to work part-time? So that's where shared decision-making really is important in choosing some of these therapies. When there is a myriad of options, which sometimes we're fortunate to have nowadays because of all the novel innovation that's going on in treatment, particularly in oncology, it's the shared decision-making with the patient to understand what their goals of care are.
And it sounds like it still will require a bit of research and effort on the physician's part to bring to that conversation with the patient. So they will still have to learn about some of these new treatments if they're faced with, having to make a decision and choose between a few that they're unfamiliar with.
Absolutely.
So, Amy, what you just described, though, it sounds to me like a version of a perfect scenario, though, right? Like a doctor in with a patient going through, okay, here's every option. Here's what we know. Consider it. I mean, is that truly the reality, though? And what are the constraints that are keeping that reality from being true? Because I feel like what you just described sounds like nirvana, right? But, it does the community oncologist listening to that would say, that sounds great, but come on, like in actual practice, I have X number of minutes and then I'm so constrained by my day that I have to move on.
Yes, I think, right. That really is the crunch. It's the time, right? So I think this is where we have to think about how different care models work in oncology. And the most effective care models I've seen are the ones that treat the oncology team as a distributed intelligence system. So different members hold different kinds of expertise and where information flows to the right person at the right moment. So the burden doesn't fall on one person to sit there with that patient for, could be 90 minutes talking about all the treatment options that are standard. And then also I have some clinical trials that you can consider. It's impossible to do that. And then the next patient you see is so angry with you because you're so behind. So the oncology medical home model is a really powerful example. So care is coordinated, it's proactive, it's team-based rather than sort of episodic and physician-centric. So basically what happens is that these practices work because they deliberately structured who's responsible for what. So maybe the physician focuses on the complex treatment decisions and prognostic conversations. Maybe the advanced practitioner does that as well, but also manages the ongoing symptom monitoring, maybe the oral oncolytic programs, the care coordination. The pharmacist owns medication management, prior authorization. The nurse navigator connects patients to resources and flags social barriers. So each person is practicing at the top of their license, and each person is responsible for staying current in their specific domain rather than everyone trying to know everything.
So you're in that unique position that, you're a practicing nurse practitioner, right? So you're having these conversations with patients. And I'm curious, are nurse practitioners the member of the care team that the patient most frequently comes to ask questions as they're trying to make that decision and understand the different treatments that are being offered to them? And then could you talk about that relationship and that conversation and what a nurse practitioner would have to keep up with to be able to be well informed and handle that conversation with patients that they're having so often?
So I think in an academic center where APs are specialized, and so there may be the AP that does only breast medical oncology or the AP that only does phase 1 clinical trials. The role of that AP is very different than an AP who might be in a general oncology practice, where we talked about how they have to do a little bit of everything. Your 9 o'clock patient can be a lung cancer. Your 9:30 patient could be a multiple myeloma patient. Your 10 o'clock patient could be a colon cancer patient. You have to know a little bit about everything. And so I think their roles are different, right? In terms of knowledge and expertise, where a breast medical oncology NP probably knows everything and the latest and greatest about breast medical oncology because that's what they see day in, day out. But in terms of how they are embedded in the practice, that can also be different from practice to practice. And I can see some practices where the AP is serving sort of in the ideal model at the top of their license, right? And they are seeing patients autonomously. They're helping making decisions. They're surfacing issues for patients. We find that APs tend to see the patients. They have the most face time with patients. I've seen a lot of cases where maybe the physician sees a patient as a new consult, and then the AP is sort of the one doing all the visits while the patient is actually on treatment. So they're managing all the symptoms, managing all the questions, and then maybe seeing the physician again for the start of the next cycle. I've seen some models where it's like an every other visit. That's probably the model I've seen the most, where it's you see the physician for this dose, the next dose you see the AP, the next dose you see the physician, so on and so forth. But I think the models that are the most efficacious is where the AP is embedded in everything. So the AP is involved in decision making, the AP is involved in tumor boards, all that stuff where they're a direct partner and not a physician extender is really where APs serve their role the best and sort of provides the optimal care for the patient and optimal workflow for the practice as well.
So one thing we haven't covered yet, though, and thank you, Amy. I think that's a great answer to Jahda's question, is the role of the manufacturer in all this and the information coming from manufacturers. So where do they sit in the broad schematic of the flow of information? Obviously, they're driving a lot of the treatment innovation, but is that something that doctors are also processing along with everything else they're trying to keep up to date with? Hey, this has come from the manufacturer and therefore I need to weigh it appropriately in my decision making or whatever I believe that appropriate impact of it should have, because I think they clearly take up a really important space in this. So, what are your thoughts there?
So I think information that comes from manufacturers is critical, right? I mean, that is all the information that came from those randomized controlled trials. It's telling you the incidence and prevalence of the side effects, how to dose, how to administer the drug, critical information. But I think a lot of practices are trying to stay clear from sort of the branded information, and they want information coming from ASCO and, ASH and big professional societies, sort of what are their recommendations? Because a lot of that is sort of the practical real world experience. And as I talked about, a lot of these patients in randomized controlled trials is not necessarily the patient sitting in front of you. A real world patient tends to have more comorbidities. They tend to be older. They tend to take a lot more medications. And like I said, they tend to be more racially and ethnically diverse than what we see in randomized controlled trials. So I've also seen direct information from manufacturers in sort of presentation formats, like dinner programs or other sort of satellite symposium at conferences. I find those incredibly valuable as well, because as I said, you're learning from the horse's mouth about how to dose these drugs, how to manage side effects from these drugs potentially sometimes. And a lot of those presentations are done by APs or physicians who are well versed in using that particular medication. So those are very beneficial too. But I do think the professional society guidelines, are really important because that is sort of heavily reliant on the real world experience with some of these medications.
But we also said, I think earlier on, what if your doctor, your community oncologist is just unable to get to ASCO, unable to get to some of those meetings, and they can't actually tap into what I guess you might consider to be a little bit more unbiased, right? And a little bit more legitimized evidence for or against the therapy that's out there. I've also heard firsthand doctors say, if it weren't for my rep, I wouldn't know.
Right. Yes.
So it must be hard for doctors to try to just take it all in, I guess is the best way to say it. And do you see doctors really applying a strong critical eye toward the information that they're getting, whether that's from manufacturers or whether that's from just completely different sources?
I do. I think a lot of practitioners, contextualize and absorb what their rep is saying, what guidelines are saying, and sort of looking at in a holistic picture and sort of what their personal experience is, what they've heard anecdotally from other providers who maybe specialize in that particular disease, and sort of making a decision from there. You can't rely on one particular source, right? You have to look at all the sources available to you and make a thorough decision based on all of that, because you can't really heavily weigh on one piece of information. But as you say, sometimes you don't have access to a myriad of resources. So I think you have to do the best with what you have in front of you and, use your own clinical judgment to make the best choice or recommendation for the patient based on what you have available.
The manufacturers also are providing resources to patients and caregivers, right? So there could be a scenario where a patient has seen a commercial or done their own research online, and they come to their doctor and say, I want this treatment. I just heard about this new treatment. How does the busy community oncologist deal with that, particularly if, they're just learning about a treatment from the first time from a patient who's bringing it to them? And I guess, how often does that happen?
I love this question because it happens all the time.
Yeah.
When a patient walks into your exam room, having done their research, having read about a new trial, maybe asked an AI chatbot about their biomarker results, having connected with a patient advocacy group and learned about a therapy that isn't even standard of care, I want to emphasize that patient is telling you something very profound. It's telling you that they are not willing to leave any stone unturned. And to me, that deserves respect and not defensiveness on the part of the provider. So patients are no longer arriving at appointments with printouts from WebMD. They're arriving with AI-generated summaries of their genomic reports. They're arriving having queried, ChatGPT on whether they might be eligible for a specific clinical trial or not. They are arriving having connected with other patients in online communities who are sharing real-time experiences with novel therapies. And this is fundamentally different from the informed patient of a decade ago. The volume, the specificity, the sophistication of the information patients are bringing to appointments has changed. And so our care models, our communication frameworks, and our training, I don't know if we've kept up with that pace and that change. And how to navigate these conversations. So I always say you first should lead with curiosity and not correction. So when a patient brings in information about a treatment or trial they've read about, the worst response is to dismiss it. The worst response is to say, that's not relevant to your case and move on. Even if the information is wrong or the trial they found isn't appropriate for them, the act of dismissal damages trust and closes the door to the kind of open communication that produces better outcomes. So the better response is to ask, tell me more about what you found. What made this relevant to you? That question does two things simultaneously. It honors the patient's agency, and it gives you crucial information about what they're afraid of, what they're hoping for, and what they value. Secondly, treat patient-generated information as an actual clinical data point. When a patient tells you that they've been using AI to research their options, it tells you about their health literacy, right? It tells you about their engagement level. It tells you about their anxiety and potentially their access to information that you haven't surfaced yet. I've had patients bring me information about trials that I wasn't even aware of. I've had patients ask questions about their genomic results that prompted me to go back and look more carefully at the data. So the informed patient is actually a resource, not a challenge. And then be honest about uncertainty. I think one of the things that these AI tools that patients are using is it surface information confidently without always conveying the appropriate level of uncertainty. So a patient can read an AI summary of a phase 1 trial, but may not understand that that phase 1 trial data tells us about safety, not efficacy. They may not understand that a therapy that shows a promise in a tiny 50-person study may not work for them. So the healthcare provider's role in this new landscape is not just to provide information, it's to contextualize information. It's to say, yes, that trial is real. And here's what the data actually shows. And here's why it might or might not be relevant to your specific situation. And here's what we actually don't know yet. And then also, I would use a conversation to understand values because, like I said, the most important thing that happens in a shared decision-making conversation is not the exchange of clinical data. It's the understanding of the patient's values. So what matters most to the patient? Is it survival at any cost? Is it quality of life? Is it staying close to home? Is it being able to work? Is it participating in research that might help others? These values should drive treatment decisions, and they're often only accessible if the healthcare provider creates the space to ask. So a patient who brings information about a clinical trial may be telling you implicitly that they want to contribute to something larger than themselves. And that value, I think, is worth exploring.
I love the passion that you just imbued throughout that entire answer. Or I mean, I'm not sure if it was an answer so much as just like, hey, this is such a better approach to AI tools and how patients are really digging into them and bringing this. Imagine, the case of primary care, and you didn't mention diagnosis, right? But patients are showing up to their primary care doctors with their diagnosis, right?
Yeah.
The reason I'm curious, though, is are you hearing a bit more just generalized pushback from doctors on what is happening in their offices when patients are showing up with that level of AI-driven information, for lack of a better term? Do you feel like some portion of their business they're saying is potentially at risk or being replaced? Do you feel like it's about where they sit in terms of being able to offer expertise and the appropriate care?
It's a good question. Just anecdotally, I think providers get a little bit overwhelmed when a patient comes in with all this generated information, because there is that classic mindset of, I have a degree in this. I went to medical school. I went to school to be a nurse practitioner. I've been doing this for years. How can your AI generated report sort of override all my clinical expertise? So I think there can be a little bit of I don't want to say a pushback, but maybe just a little bit of a bristling when that's first presented to you in the exam room. And I don't think that's necessarily wrong. I think it's a perfectly natural to react that way, but I think we just need to sort of widen our mindset and think more about what that actually means when a patient is bringing that to you. And so I like to think that most providers are a little bit more interested in being open-minded. And even in the setting with their patient, I don't think they're automatically shutting them down openly. I think maybe inside they're bristling a little bit, but I think they do want to open up the conversation more. And I think they do want to understand sort of what makes that patient do all that research. Is it because they're an advocate for themselves? Is it because they, just want to know more of what's out there? I think we should honestly have more concerns about the patient that is sitting there silent and not asking questions and having more of a paternalistic style of a visit with the provider. Those are the conversations I think that are most concerning to me, because is the patient actually participating in their care? Are they just sort of just doing whatever you say? And those to me are not necessarily the best way to go about clinical decision making. And that's not even shared decision making, right? So I actually prefer, even though your visit could be longer with that patient who brings the report, it does show you that they're invested in their care and they want to participate in their care and they want to understand what's going on in the treatment landscape, versus the person who's just sitting there sort of maybe glazed eyed not really remembering what we were talking about in the visit and just sort of going through the motions. I think those patients are really the ones that get lost in the sauce. So I think that we need to be more welcoming, and not saying that we're not, but I think we do need to be more welcoming for these patients who are really invested in their care and bringing information to us and just channeling that information into a more productive conversation and explaining to them why and why not whatever they brought is applicable to them.
I think it sounds like an educational opportunity as well for physicians, right? Some role-playing scenarios,
Yes.
especially for those who maybe aren't of the ChatGPT generation, to help them be better equipped to handle those conversations when a patient maybe surprises them with pages of clinical trial data that they weren't even aware of.
I suspect there's still probably more patients that are not showing up with anything that's been generated by AI. The folks of us right here in this conversation are used to being more on the cutting edge because it's our profession to stay there. But I think about my mother, who's approaching 80, who's a breast cancer survivor. And is she consulting AI on anything she's experiencing in her life? No. No offense to my mom, but she can't even use the TV remote, So there's so I do think that what I think I would hate to see is patients truly getting left behind, because if a doctor doesn't sort of treat that as an input, it kind of goes both ways. Like, hey, this patient is showing up with nothing and they need all the help I can give them, versus this patient is showing up, heavily armed with all the information at their fingertips.
Right.
You mentioned real world evidence and clinical trial criteria, not necessarily including the many different diverse types of patients that exist in the real world. And so I wonder how much a lack of real world evidence, particularly if you're talking oncology and maybe something that got an accelerated approval, how much does a lack of evidence in some of these real world patient types, different ethnic groups, patients with certain comorbidities, how much does that prevent physicians from adopting new approaches? Is that a barrier, you think?
So clinical trial eligibility criteria can be very stringent. You really have to have sort of the perfect organ of function, the perfect labs, no comorbidities to be eligible for the clinical trial, which, as you know, is not necessarily the patient sitting in front of you. But, actually at Flatiron, we did some work where we were able to tweak eligibility criteria to certain trials to see how much it would widen the eligibility for patients to be in the trial. So, for example, maybe there is some sort of inclusion criteria or exclusion criteria that doesn't necessarily influence any sort of toxicity or tolerability to the drug. Maybe you need a platelet count. It says you need a platelet count of 75, but what if you have a platelet count of 60? Is that okay? And if you can tweak it a little bit, it can show you maybe more patients are eligible, but it doesn't necessarily hinder safety or tolerability at all. So things like this we need to consider, maybe making clinical trial eligibility criteria a little bit more along the lines of looking at who's eligible for it, as opposed to just copying and pasting from a prior protocol that had the same IE criteria and not actually looking at the context of the clinical trial and the population you're trying to treat. Because that happens, right? It's a lot of work to rewrite another protocol. If you're just copying and pasting from a prior protocol, some of that can get lost in the sauce.
Do you think that it influences physicians' behavior in choosing between something they've been using for years versus a newly approved therapy that perhaps doesn't have a large body of evidence in the particular demographic of patients that they may be treating in their practice?
I think some clinicians do have that level of choosing something that they're comfortable with and they're well experienced with. And then you do have those physicians or clinicians that are willing to make that leap and try something a little bit different for the patient based on the literature that they've seen, but maybe they've never used the drug before. And then that's when they really rely on their pharmaceutical rep, right, to help guide them through it. But I definitely think you have both. And that same person can be doing both. I think it's also a conversation you have to have with the patient and be completely honest. We have regimen X. We've done it a lot. This is my experience with it. This is how I think it help and hinder you. But there's also this new approval that's really exciting. The data shows this. I've spoken to this person about it. I've seen it presented in this case-based study. I've spoken to, the rep for that manufacturer. And I think you would be a great candidate to try this new treatment. And we can sort of learn as we go. Just have that honest conversation with the patient and let them even help you make that decision. Maybe they're not comfortable trying something new. Maybe they want to first try your tried and true. And if that doesn't work, maybe switch to the new thing. And do we have even time to do that also? So where are we in the disease? Are we with full blown symptoms that need to be controlled rapidly? Or do we have time to sort of try either one and make a decision if things change, the status changes along the way?
So as we look to kind of wrap up this conversation, I think it's been great. And Amy, I want to leave you with an opportunity to wrap us up. And I want to give you a chance to just speak for a moment to every community oncologist in a country who is feeling the burden of that pace that they're asked to keep up with relative to the information they need to learn to do their practice the right way or the best way that they know possible. What are one or maybe two things that you can offer them to give them hope for what the next few years are going to look like for them?
So one thing I do want to speak a little bit on is the concept of burnout, because that is something that's very real for our healthcare providers today. And I think when we think about burnout in oncology, it sort of puts the onus on individual clinicians rather than sort of naming the systemic failures that have created the situation. And burnout rates are really pushing high for medical oncologists, up significantly from a decade ago. And we're even seeing a lot of reports of people leaving the oncology field. We're training medical oncologists a certain number per year, but I think we're actually losing more than that per year to retirement. And so that math doesn't work. It has direct consequences for patient access to care, particularly in underserved communities. And so what I want to speak on is that at APSHO, the Advanced Practitioner Society for Hematology Oncology, we recognize that almost all the burnout literature focused on physicians. There was actually very little data on what was happening in HemOnc advanced practitioners. So the nurse practitioners, the physician assistants, the pharmacists, who are often the backbone of the cancer care delivery, especially in community settings. So we did something about it. We launched a dedicated burnout survey of HemOnc APs, one of the first of its kind, specifically designed to understand the scope of the problem in our profession and generate evidence we need to formulate real management strategies. And what we found was alarming. From even our compensation survey that we administered, we already knew that up to 30% of oncology APs were considering leaving their current position. And a number that, if realized, would have profound consequences on the cancer care workforce over the next few years. And this is a population that is disproportionately female, right? Disproportionately mid-career, disproportionately working in the community settings where the most vulnerable patients receive their care. So if we lose those providers, we don't just lose clinical capacity, we lose the relation continuity that's often only the thread connecting underserved patients to the healthcare system and all. So in response to these findings, APSHO developed a dedicated educational module called Preserving Our Passion, Burnout Recognition and Management, drawing directly on our survey data and community input to help APs recognize the signs of burnout in themselves and their colleagues and develop concrete mitigation strategies. And at our conference a year or two ago, addressing burnout in APs was identified as one of the central themes of the entire conference, a signal that this is no longer a sort of a peripheral concern, but a defining challenge for our profession. And what strikes me about all of this is sort of the equity dimension that often goes unspoken in these burnout conversations. So when we talk about burnout in oncology, we're not just talking about sort of the individual suffering of that provider, although that matters enormously. We're talking about a workforce crisis that will fall hardest on the patients who are already most vulnerable. So those in the community oncology practice, where they serve the most diverse, most rural, more socioeconomic disadvantaged patient populations, those are the ones least equipped to absorb workforce losses. They don't have the deep bench at the academic medical centers. So when a nurse practitioner in a rural practice or a safety net hospital in an underserved urban neighborhood leaves, that's not just a staffing gap. That's a patient who now has no one to call when their symptoms change, no one to navigate their prior authorization, no one who knows their name and their story. So when I think about burnout, I think about also as a health equity issue, not just a workforce issue. And that's why we're doing so much work to measure it, name it, address it. We can't bring patients within reach of quality care if we're burning out the very people who deliver that care.
So where can we direct all care providers to learn about what you just mentioned?
Yeah, so you can go to AppShow's website. We have all that data published. We also published it in a journal as well. AppShow's website is www.apsho.org.
Fantastic. Well, Amy, Jahda, thank you so much. It's been a pleasure. I hope you've enjoyed this conversation. I know I have.
I did. Thank you so much for having me. This has been really great and a really fruitful discussion.
Thanks, Evan. Thanks, Amy.
So what about Janet? It's tough to argue with what innovation in the field of multiple myeloma has done for her. She went on Cilta-cel in 2023. Her hemonc was so on the ball that she was on the waiting list before she even had a chance to ask him about it. So when her measurable residual disease showed up negative and she got a chance to ring the bell, she rang that thing so hard you might have felt it wherever you were. And I bet the bell felt like a steamroller had hit it, which I'd say was true. A steamroller named Janet, a walking testament to human perseverance, humor, and the value of innovation. Thank you for joining me on Within Reach, a podcast hosted by me, Evan Young, and produced by Avalere Health with the help of Podcast Labs. For more Within Reach content, including in-depth reports about cutting-edge topics in oncology, patient stories, articles, and more, visit withinreach.avalere.health.com. You'll also be able to meet our SenseMaker experts who have worked hard to bring Within Reach to life. To get in touch, email us at withinreach@avalerehealth.com or follow us on LinkedIn. And who is Avalere Health? Avalere Health is a global strategic partner for the healthcare industry, working across the breadth of the product lifecycle to ensure every patient is identified, treated, supported, and cared for equally. Our advisory, medical, and marketing teams come together powerfully and intentionally to forge unconventional connections, building a future where healthcare is not a barrier and no patient is left behind. If you'd like to support Within Reach, please leave a review on Apple Podcasts or wherever you get your podcasts. Your input helps us make the podcast even better, points us to topics that are relevant to you, and helps us reach new listeners. All you have to do is open up the podcast app on your phone, look for Within Reach, scroll down until you see it, write a review, and tell us what you think. Join me next time as we continue to uncover issues in oncology and work toward their solutions here on Within Reach from Avalere Health.